audience. I'm Doug Wood. I'm the chair of the Department of Surgery here, and really welcome all of you to our 76th annual Strauss Visiting Professorship. And I'm going to give a broader introduction to Dr. Farmer in a few minutes, but we're very fortunate in this visiting professor program to have our Dean and CEO of UW Medicine, Dr. Tim Dellett, here. And Dr. Dellett is going to give some introductory comments about the Strauss, Alfred Strauss and the family and our visiting professor program. Thank you, Dr. Dellett.
Well, thank you very much, Doug, and it's a real pleasure to be with everyone here this afternoon. And as Doug mentioned, it's really a privilege for me to share a little bit about the impact of Dr. Strauss on the University of Washington, our School of Medicine, and then obviously also the medical community in Chicago during his really amazing career. So in presenting the 76th Annual Strauss Lecture, the Strauss-Friedlander family is carrying on the tradition established many years ago by Dr. and Mrs. Alfred A. Strauss. Born in Germany in 1881, Dr. Strauss came to Colville, Washington at the age of 10. He was an honor graduate of the University of Washington in 1904 and an outstanding member of the Alumni Association. And in fact, he received the single honor of alumnus summa laude dignatus in 1951. When he was a student as an undergrad at the University of Washington, he was a football and baseball star. As an alumnus, he was active in the recruitment and establishment of scholarships for athletes at the University of Washington. And I always find this amazing. He actually personally recruited 75 football players from Chicago to come play at the University of Washington, 5 of whom went on to become All-American. In 1981, he was elected to the Husky Hall of Fame. Dr. Strauss received his medical degree at Rush University of Chicago Medical School in 1908, graduating first in his class. He interned for 2 years at Michael Reese Hospital in Chicago, and then completed a brief surgical fellowship under Professor Enderlin in Heidelberg, Germany. He then returned to Chicago, where he spent his entire medical career. Dr. Strauss possessed a rare combination of skill, vision, and drive, and was intimately involved with many of the first in advancing medical care, including refinements of pyloroplasty, subtotal gastrectomy for peptic ulcer disease, surgical advances for inflammatory bowel disease, and the first description of an abdominal wall zipper to allow re-exploration. Dr. Strauss and his 2 physician brothers, Herman and Siegfried, also University of Washington undergraduate alumni, founded Weiss Memorial Hospital in Chicago in 1953. Dr. Alfred Strauss is also well remembered for his influence in the founding of our own University of Washington School of Medicine. In 1944, he was a member of the proposed medical school committee. He met with Governor Langley, strongly advocating the state for funding for a new medical school. Subsequently, an appropriation bill was signed by the governor in March of 1945, and then we admitted our first students in 1946, beginning our School of Medicine. True to his continued interest in this institution, Dr. Strauss sponsored a surgical lectureship in 1950 for the Department of Surgery, and these lectures have been a prestigious annual event ever since. Today's program marks the 76th anniversary of this event and is supported by the Alfred Strauss Endowed Lectureship in Surgery, established by the estate of Mrs. Marjorie Friedlander, daughter of Dr. Strauss, and annually supported by generous contributions from Dr. Strauss's nephew, Dr. John Strauss, and grandson, Mr. John Friedlander, the son of Marjorie Friedlander. And again, we are very fortunate to have both Dr. John Strauss and Mr. Friedlander here with us as we celebrate this 76th anniversary of this lectureship. So again, it's a great honor to be with you here today, and I'll turn it over to Dr. Wood.
Thank you, Dr. Dellett. And I also want to add my appreciation to Dr. John Strauss and John Friedlander and Betty, who are here. reliably every year supporting this really important program that is the anchor of a great day of the Harkin Symposium. And I'll just make a couple of comments before I introduce Dr. Farmer. A day like today lifts my spirits. When I see the breadth and depth of what our people are doing, and this is just the surface, they're just the ones that we were able to present today. If I get discouraged sometimes, I just have to think about a day like today when we're together in this room and seeing the creativity, the innovation, the dedication, and the intelligence of our faculty, our residents, our fellows, and the people that all of you are that make this department what it is and fulfill our mission that of caring for patients, our mission of training the next generation, our mission affording research that improves how we care for patients. So I just want to give a thank you to all of you. Thank you for being here, and thank you for those that presented, because you made my day. Well, my day is also good because of having a friend, Dr. Diana Farmer, here. And Dr. Kandawal gave an introduction to her this morning. Some of that will be repetitive because we have some additional people in the audience, and I don't want to miss any of the accolades that Dr. Farmer deserves. Dr. Farmer is an internationally renowned fetal and neonatal surgeon. She's a distinguished professor and the Pearl Stamps Stewart Endowed Chair and Chair of the Department of Surgery at the University of California, Davis. There, she's also the Emeritus Chief of Pediatric Surgery and the Chief of Pediatric Surgery at Shriners Hospital, Northern California, and a founder and co-director of the Center for Surgical Bioengineering. So, the more I know about Dr. Farmer, I find lots of places that our paths have interconnected, but I'll go backwards all the way to undergraduate, where Dr. Farmer went to Wellesley College. But then I think a fact that's come out for many here that they didn't know about Dr. Farmer is that she is Idaho Whammy University of Washington. So here is evidence of the success of the WWAMI program in somebody who came from Idaho, is an Idaho WWAMI graduate of UW School of Medicine and is chair of surgery at one of our peer institutions. Many of you saw that Dr. Farmer had several intervals of training, including some time as a Luce Fellow, L-U-C-E, not L-O-S-E, fellow in Singapore. And then she was a general surgery resident here at the University of Washington for 2 years before, for personal reasons, moving to UCSF, where she completed her residency. She then did her pediatric surgery fellowship at Detroit Children's Hospital. And I didn't know at that time that you were considering maybe cardiothoracic and staying at UCSF, but we miss you from cardiothoracic, but we're glad that you trained as a pediatric surgeon, given what we now know, everything that you've done. Dr. Farmer initially took a faculty position for 3 years at the Children's Hospital of Detroit before she was recruited back to UCSF and went through the promotion process and was at UCSF for 13 years and promoted to professor. And then she was recruited to her current position at UC Davis to be chair of the Department of Surgery. As a recognized leader in pediatric surgery and fetal surgery, she's especially known for her skilled surgical treatment of a number of congenital anomalies and for expertise in cancer, airway, and intestinal surgery in newborns, and especially for her investigations in the safety and efficacy of providing spina bifida treatments before birth. Dr. Farmer's lab focuses on regenerative medicine, specifically in utero cell therapy for myelomeningocele, the most severe form of spina bifida. In 2000, Dr. Farmer's team made the seminal discovery of that hindbrain herniation could be ameliorated by prenatal surgical repair in fetal sheep. This this breakthrough led to a $22 million multi-center management of myelomeningeal seal study, or MOMS, a randomized human clinical trial of closure before and after birth. And this trial showed conclusively that fetal surgery resulted in better outcomes. Dr. Farmer is now developing allogeneic placental mesenchymal stem cells to further treat in utero spina bifida. Her lab has received investigational new drug approval with the Food and Drug Administration, and patient enrollment in the cure and cellular therapy for uteral repair of MMC clinical trial is currently underway. Where I have seen Dr. Farmer is numerous awards throughout her career. She has the singular honor of being elected to the National Academy of Medicine in 2011. She's a past president of the American Pediatric Surgical Association. She's been chair of the Board of Governors of the American College of Surgeons. She's long been a leader in global surgery. In 2016, she founded the Global Initiative for Children's Surgery, which aims to improve pediatric surgical care in underserved areas. He is currently a regent of the American College of Surgeons, a recent past president of the American Surgical Association, and another recent past president of the International Fetal Medicine and Surgery Society. Dr. Farmer clearly has been a leader in fetal surgery, and importantly to us, a mentor, partner, and collaborator of Shin Hiroshi, who we recruited from UC Davis earlier this year to lead and develop with Dr. Mary Austin our fetal surgery program. And there is a purpose of having Dr. Farmer here, besides all of these other connections, is Dr. Farmer is a pioneer in fetal surgery, and we are working on developing our fetal surgery program here and continuing the work that Dr. Farmer has been doing and bringing it to the Pacific Northwest with the team that we've recruited here to Seattle Children's Hospital. So, Dr. Farmer, it's an honor to have you here as our 76th Strauss visiting professor. Thank you. We look forward to hearing from you.
Well, indeed, it is a true honor for me to be back here where not only my medical, but truly my personal journey began. I'm officially the class of E79 is how they say it, your entering class. It's very smart of the University of Washington because they know lots of us take little journeys and it doesn't predict when your graduating class would be. But I also officially graduated. But it is a real honor to be here to deliver the Strauss lecture and to have enjoyed the opportunity, which is kind of rare in many of these named lectureships, to spend time with the descendants of Dr. Strauss and his amazing family and the commitment that you show to this work. I hope this lecture will be equally interesting to some of the amazing ones I've seen in the past. And I truly, again, appreciate you being here. As I enter the twilight of this long career, I realized that it was important for me to honor and thank a few of the people that have been so instrumental in this journey, this University of Washington surgery journey. First, I just want to start out by saying that surgery was in my blood and I didn't really know it, but I have a great grandfather, uncle, who was a surgeon. They weren't pediatric surgeons then. As well as my grandfather, who I never knew. He died when my father was 13, was also a surgeon in rural Nebraska. So I looked this up I've appreciated the legacy of having a family of surgeons one comes from. So you helped me recoup that history. But important people that I want to share and discuss is the critical value of friends, of family, of cherished colleagues who are so important and have been so important to the success of my surgical career. So first, I have to introduce the 4 other whammy women that I started with at the University of Idaho. And I'm going to embarrass Sam. But Sam, will you please stand up? Because Sam's mom is Molly Mantrack. But it's the friends we make along the way and the colleagues that we have that make it all so meaningful. And then I just have to say, for me, people like Jim Carrico, Ron Mayer, Kai Johansson made it all possible for me. Little things in that very first year of being an intern, being a medical student first, really. Ron, I don't think when I first re-met him, honestly remembered me as a medical student. But when I reminded him that my H&Ps were full of red grease pencil, he knew I was telling the truth, because that is how he used to grade your H&P. Had a lot of red grease pencil on them when I was a medical student. And then Kai, as many of you, Dr. Johansson, as many of you heard this morning, was the one surgeon who said to me when I was chickening out of going to Singapore as a loose scholar, because everyone said you'll never get into a serious field like surgery. And Kai took me aside and I looked up to him and he said, "Are you crazy? This is a once in a lifetime opportunity. You go to Singapore, you take this, and we'll figure out how to get you into surgery when you come back." What I haven't said publicly before is that I actually did end up doing my internship here at the University of Washington for free. Now, the dean doesn't need to hear all of this, but, and that's a long story that is a legacy of the times. But Kai, it was worth every minute, and thank you. There are also many people on this slide that many of you don't know, but I would encourage you to take a moment to sort of find out who your sort of ancestors, if you will, were in the departments and the divisions that you're in, because they made many, many amazing contributions. And it's just a reminder that you have no idea which medical student you will impact, which intern whose life you will change. So every interaction counts. Then I will say, many of your contemporary leaders, Dr. Pellegrini, who I knew in San Francisco before he came to be the chair, Doug, who has shared, we have been good friends since we started working. But with that long-winded introduction, let me just say, today, when I look at surgery, I am truly struck with the ever-increasing corporatization of medicine and the changing passions and priorities of our medical students and our junior residents. I believe that fundamental change in the healthcare system is coming. Our current rate of insatiable growth in cost, combined with the growing physician dissatisfaction that we see every day, and frankly, the complete failure to improve the health of the population in this country by almost all metrics, including increased infant mortality, decreased life expectancy, and the return of previously eradicated infectious diseases. All of this demand change. Creation of our current for-profit industrial medical complex has created great wealth, but not great health. I, however, am personally most worried about how to preserve scientific creativity and innovation in the face of all these challenges. Surgeons have made great contributions to medicine and humanity. In fact, there have been 11 surgical Nobel laureates. Emil Kocher for thyroid physiology, Alvar Gulstrand, refracted light in the ocular lens, Alex Carroll, blood vessels and transplantation, Robert Baronet, the functioning of the vestibular apparatus. You see, almost every field of surgery has a Nobel laureate associated with it. Frederick Banting, extraction of insulin and diabetes, also a surgeon. Alexander Fleming, the discovery of penicillin, a surgeon. Rudolf Hess, brain mapping for control of the internal bodily functions. Werner Forsman, cardiac catheterization, surgeon. Charles Huggins, we're getting a little more contemporary, hormonal control of prostate cancer. Joe Murray, organ transplantation. And Shinya Yamanaka, who I think many of you may know about iPS cells, don't realize he was an orthopedic surgery resident before he quit and spent full time as a stem cell scientist. So all of these people have made contributions that laid the foundation for entirely new fields of surgery and medicine, cardiac, transplantation, things that would not have existed. And I would argue that had surgeons not innovators, these fields would not have existed. So today I'll talk a little bit about my own journey through an amazing field, fetal surgery, and how it led to my current work on developing a stem cell therapy-based engineering approach to one of society's most tragic, really tragic birth defects, spina bifida. And I'll talk a little bit about the joy of discovery, which I gave you a hint about this morning, and the joy, the true joy that this journey has brought me, in the hopes that it will inspire some of you to follow. So fetal surgery, operating on the fetus in the womb, it's a very simple concept. Just like heart surgery and transplantation, opened an entirely new field. For centuries, the fetus was shrouded in mystery. Think about your grandparents. They'll talk about, waiting for the baby, counting finger and toes. When the baby came out, there was not much we could do. But along came a disruptive technology, really in the 1970s, ultrasound. And that mystery, of course, was revealed. But much investigation had to occur before the field of fetal surgery could be realized. Initially, ultrasound was very primitive and primarily used to determine whether or not the baby was breech or could be delivered vaginally. Occasionally, the obstetrician might see something unusual, serendipitously see a defect. But again, there wasn't much you could do beyond managing the expectations for the family. We pediatric surgeons were experts in treating birth defects after birth. And although we could technically repair the hole in the diaphragm, the damage had often already occurred, and the baby wouldn't survive because the lungs failed to develop. So pediatric surgeons had struggled with these problems for generations. What was groundbreaking was for someone to ask the very unbelievably simple question: what would happen if we fixed these things before birth? And if you look back at many of the great discoveries, they are really begun with just a very simple observation and a simple question. Maybe that's the beauty of surgeons. We're kind of simple-minded, I guess. Let go. But the premise of fetal surgery was beautifully succinct. There were simple anatomic lesions that led to disastrous physiologic consequences. But it took Al DeLormer and Mike Harrison, who I mentioned earlier, to do the rigorous investigation, really a decade and a half of investigation that ultimately led to the first operation on a fetus in the womb in 1983, the year I graduated, by Mike Harrison. He had finished his training at the Mass General and the Children's Hospital of Los Angeles and came to UCSF to join the only pediatric surgeon there at a time who was studying with the Cardiovascular Research Institute people how to unravel the mystery that you also heard about this morning of the complicated changes in cardiac flow, in blood flow that occurred at birth. But they took the time to take 3 very important steps that were necessary to successfully launch fetal surgery. Because if they had just done it without approval, with just out of the get-go, this would absolutely have been a disaster. So the first thing they did was define and study the natural history by ultrasound, by serial ultrasound. And what they discovered was that there were many things that in fact looked terrible in the first trimester, big masses and cysts that disappeared by the 3rd trimester or by the time a baby was born. So had they just gone sticking needles into these things that they saw, again, disastrous consequences, lots of backlash, this field would never have occurred. So what they observed, which is equally important in all that we do in surgery today, was not just when to operate, but also when not to operate, an important observation. Second, they had to study the pathophysiology in animal models. They had to ask the question, was the hypothesis really true? If you do it before birth, would it make a difference in the physiologic outcome? And in fact, here's where the fetal sheep model, you guys saw some of my sheep earlier, was so critical. It turns out that sheep are quite resistant to preterm labor. So you could make a model, make a defect, close them up, let the defect sort of mature, and then go back and do an operation again. Now, too bad we haven't figured out why sheep don't have preterm labor yet, because that would be another good problem to solve. So there's a problem for any of you folks in the back. But I wanted to then describe the third most important step, and that was to study maternal safety. Because again, here the mother is truly an innocent bystander. Just like liver transplantation, she has no medical benefit for herself, yet undergoes all of the attendant risks of a relatively serious operation. And certainly the ethics of fetal surgery, similar to those of living-related liver transplant, could be an entire lecture in and of itself. There is, however, one profound lesson I would like to share. In the early days of fetal surgery, the Right to Life community was fervently against fetal surgery. It was felt that we were violating the sanctity of the womb. We did the operations at 3:00 in the morning. We didn't mark them on the OR board because we didn't know who in the environment might think that this was wrong. Interestingly now, fetal surgery is the darling of the Right to Life community because it's an alternative to pregnancy termination. But what does this show us? What this shows us, what does this tell us, is that as scientists, we must stay above and out of the political fray because societal mores always change. And I will say Mike Harrison stayed laser focused on the fetus as a patient and stayed out of the conversation of whether the fetus was a person. That debate is still going on fervently today, and this field would never have occurred without that. So while all aspects of maternal safety and the daunting technical aspects of early fetal surgery also required discovery, how to open the pregnant uterus without the woman hemorrhaging to death, how to keep the uterus from contracting in response to injury, and how to maintain the pregnancy for the next several months, how to restore the amniotic fluid, how to create a watertight closure that wouldn't leak through the continued rapid growth in the size of the uterus itself. All of this had to be elucidated in the most rigorous of models. And for this was the non-human primate. Though the sheep uterus was ideal to explore fetal physiology, it has entirely different placentation and uterine activity from a human uterus, which is quite muscular and vascular. It requires tocolysis, special medicines to prevent preterm labor, and it's monochorionic, one big placenta. Another little story, a fact that also proved to be key in the development of fetal surgery, was that we use the typical TA90 staplers. There's probably also not too many people in the room. Those are the big staplers we used to use for lung resections. We don't really use them anymore. But they were ideal for bloodless uterine entry. But interestingly, those metal staples acted like an IUD in those monkeys, and they could not go on to have subsequent pregnancies. So again, had that work not been done, this field also would have died, because no one would have said you should be doing fetal surgery if that means a mother can never have another child. So had this not been discovered with rigorous animal modeling, it would have taken actually also many years to discover why the women weren't having future pregnancies in this field. So interestingly, from a maternal safety point of view, open fetal surgery has been exemplary. Its mortality track record exceeds that of living-related liver transplant. Thousands of fetal lives have been saved in otherwise doomed pregnancies. And to my knowledge, there have only been 3 maternal deaths worldwide in this field, which is actually quite extraordinary. And in fact, none in this country, and only 1 in this country from a fetoscopic procedure, which is, arguably supposed to be safer. I think all of us that do percutaneous interventions know, in many ways, it's scarier because you have less control than you do with an open operation. But so where are we today? Where is the field today after 40 years after the first fetal surgery? Fetal surgery is now performed worldwide. There are over 10, I guess I'm going to have to change it to 11, full-service fetal surgery centers in the United States, with many more that just offer fetoscopic procedures for things like twin-twin transfusion syndrome, where two fetuses share the same placenta and one steals the blood supply from the other. That used to be an 80% mortality. With that, you'd lose both babies. Now there's over an 80% survival of that. In fact, twin-twin transfusion is the most common fetal procedure. Other conditions that are currently amenable to fetal intervention are certain in utero tumors that cause fetal heart failure, fetal lung lesions, fetal airway obstructions. Recall for a minute that the fetus doesn't have to breathe while in utero, as oxygen exchange comes through the placenta. But of course, the first thing you have to do when the baby's born is whack them on the behind and get them to breathe. Certain congenital heart lesions, diaphragmatic hernia, urinary obstructions, and now spina bifida, as you heard a little bit about this morning, the first of the non-fatal fetal defects. There are many technical lessons that have been learned about the safe performance of fetal surgery, including bloodless uterine entry with the then specially made absorbable stapler, management of the fetal membranes, the need to prevent handling of the umbilical cord, to prevent potentially devastating umbilical cord spasm, the reality that surgery for the fetus is anesthetized through maternal transmission of inhalational agents, lack of need for fetal intubation. It's very weird in the beginning to do an operation and look down and realize your patient's not intubated, but you're doing this big operation on the neck. So it took a while for the surgeons to get used to this as well. And of course, really only have one chance. You can't go back for bleeding. You can't do another operation. And the womb still remains the best fetal intensive care unit. The greatest consequences of open fetal surgery, however, are for the pregnant woman the need to avoid subsequent labor to avoid the risk of uterine rupture. It's like old classical cesarean section. And we're working constantly to try to make that better. In the early days of fetal surgery, as I mentioned, only fatal fetal defects were a reasonable risk for fetal surgery. But as maternal safety has improved, we began to think about non-fatal defects. And that has ultimately been the focus of my work for the last 2 decades, spina bifida, or myelomeningocele, which, by the way, I apologize, Doug, is so hard to pronounce. So, spina bifida is the second most common neurologic birth defect. It affects 4 children every day born in the United States. It results in lifelong disability with paralysis, incontinence, sexual dysfunction, cognitive disabilities that are associated with the Chiari-2 malformation, which leads to hindbrain herniation and hydrocephalus. The cost to society is enormous, with greater than $200 million in annual costs for each child with myelomeningocele in the U.S. Spina bifida is thought to be explained by a 2-hit hypothesis. First hit is the primary defect in neurulation. The spinal cord and the spine don't develop. This occurs about 6 weeks of gestational age when the neural tube is supposed to close. The second hit, which is what we attempt to deal with, is the damage that is caused to that exposed spinal cord. If you think about it for a minute, your brain and your spinal cord are the only organs that are encased in bone. The rest of our organs kind of hang off our bony spine, which of course the orthopods will tell us is the most important, why they're the most important, but that's a separate conversation. So the evidence is that it's the toxicity of the amniotic fluid plus just the mechanical trauma of that delicate developing spinal cord up against the uterine wall. So the question was asked, could we cover that spinal cord before birth and reduce some of that secondary damage? Again, a very simple question, same question. Would we change the pathophysiology if we did the operation before birth instead of after birth? So back to the fetal sheep lab, Martin Muley, Claudia and his husband's a plastic surgeon from Germany, came to work from Switzerland in the Harrison lab, started this work, and showed that, in fact, it looked like it was true, that if you did work before birth, it would make a difference. Now, for me, as a woman who had spent a fair amount of time in global health by this time in my career, I knew that this was the defect that would catapult fetal surgery into worldwide use. Spina bifida was tragically debilitating and very common throughout the world. And in fact, if you travel throughout the world and see children in little red wagons with big heads, those often are children with essentially unrepaired spina bifida. Historically, the only reason that this was closed at all at birth was to prevent meningitis, to prevent infection as the child went through the birth canal. So no one thought you could actually make any of these children better or improve their paralysis. We needed a definitive clinical trial before this very high-risk fetal procedure became popularized worldwide and women were harmed. So drawing on my experience that I shared about working for the DuPont Merck pharmaceutical company as a resident, where I did large-scale clinical trials, I knew that we needed a primary outcome variable that would be independent of the level of that lesion. And my lab, including Bettina Peck, who now works for you, were involved in the seminal discovery in lambs that if you made a CSF leak, you could get hindbrain herniation. And if you made that leak go away, the hindbrain herniation would go away. So this is what led to the work ultimately that led to the MOMS trial. Now, I just have to say, I wrote that initial grant as a fetoscopic trial, and it got turned down. We talked earlier about the importance of not giving up, of being persistent. And in fact, we didn't give up and we resubmitted. And ultimately, it became the MOMS trial. All trials these days, if you haven't noticed, all need a neat acronym. This was pretty good. Management of myelomeningocele, we thought. So the MOMS trial was an extraordinary trial. It demanded that there were no backdoors, and I think I shared that the rest of the fetal surgical community agreed not to do this operation and let it be done for the trial. It would be hard to get that level of equipoise, I think, today, but it's an important reminder of when really important questions need to be asked and answered. We all should come together, regardless of the competition, et cetera, and do the right thing. Design of the trial was simple. There were 3 centers, UCSF, CHOP, and Vanderbilt, so it's 3 areas of the country, and very simple randomization. You either got the surgery before birth or you got the same surgery after birth. So it was funded by the NICHD. It lasted 9 years, and I think I had mentioned that it was actually closed early because of efficacy. Again, an uncommon finding. None of the investigators had any access to the data. That was kept at a central site. We actually thought we would get closed down because we were recruiting so slowly, so it was a surprise. But the benefit was staggering enough to close the trial early. The need for ventricular peritoneal shunting went from 82% who have the operation after birth to 40% for those who had it before birth. I mean, if we cut cancer in half by one single trial, that would change practice overnight. And in fact, it did change practice overnight. That essentially fetal surgery is now the standard of care for an eligible woman. What was interesting, the other observation that was found in this trial was that it reduced by some the need for, it increased the ability to walk. Again, the trial was published in the New England Journal of Medicine and changed practice almost immediately. It also didn't require much of a change in insurance company coverage because they were still paying for the operation after birth. So paying for it before birth wasn't that much different. And as you heard from one of your speakers earlier today, the influence of insurance and financial benefit for patients also impacts how healthcare is delivered. So this was a big trial. It won Clinical Trial of the Year in 2012. The results were exciting. But what I took away also was that 60% of the children still had disabling lower extremity paralysis and were unable to walk. Go back and you remember that I had done this early work as a research resident after the University of Washington as part of the IL-2 lac cells for cancer. So I happened to be at the ground floor of also cell therapy as a new. So I had to work with I had to learn about spinal cord injury. So I went to San Francisco General to work with the experts there. And they were collaborating with a PhD bioengineer at Berkeley. So I met with them and decided maybe we could use some of their theories to apply to our prenatal spinal cord injury problem. Well, there I met the postdoc who was doing all the work. Now, if anyone has worked around placentas, the first thing you'll know, they're really, really stinky. But here was a guy, enthusiastic as ever, working on the stinky placentas, figuring out how to get stem cells. And I said, that's the guy for me. So when I moved to UC Davis, I brought him with me, and we have been scientific partners ever since. And it is so meaningful to have that unbelievable professional partnership where you can ask questions and help each other. And it's just been so much fun. So since then, we founded the Center for Surgical Bioengineering. We have a lab that has 70 people in it now, and it's just extraordinary. So I will skip the 3 years of things we tried, IPS cells, 905 scaffolds, all the things that didn't work. But frankly, that's an important part of the story too, all the years of things that didn't work. I mentioned earlier that I have always been fascinated by the placenta. We hypothesized that if we could incorporate biologically active stem cells, that we perhaps could improve neurologic function. Again, we didn't know what we really needed. Was it neuronal tissue replacement? Did we need to make more spinal cord? Did we need to restore the normal anatomy? Did we need cell protection? But we got there. Again, fascinated by this placenta that grows and becomes senescence over 9 months, does all these other things, immune organ, endocrine organ. It has amazing powers. We began discussing fetal tissue engineering. We thought, as I mentioned, that we would need autologous cells, the mom's own cells, but here the fetus is biologically similar, identical, actually. So we worked on chorionic villus sampling using early gestation cells, which are different, and used them as the source of cells for our material. This has all been replaced now, chorionic villus sampling, by peripheral DNA in maternal blood sampling. So you can do prenatal diagnosis with just blood sampling with mom. But imagine if what was a diagnostic procedure could now become a therapeutic procedure. In any event, we learned, as I described, that they have multipotency, more than just bone marrow stem cells, not quite embryonic stem cells. They could generate 2 lineages, mesenchymal cells as well as ectodermal cells, and had all of those interesting paracrine secretion profile that I showed earlier. We knew we were onto something interesting, and we went back to the fetal sheep lab, as I showed you before. And just for people who didn't see it, because they're so cute, we ultimately tested them in the bulldogs after birth as proof of principle to see, do these cells, could they make a difference? And here, pre-birth, they're on their hocks, whereas here you can see he's up on the pads of his feet and doing well. So we made some adjustments to allow us to focus exclusively on the distal neurologic function to see that it would last long-term in the animals. But eventually, after much trial and error, we discovered that these cells, properly engineered and seated on an appropriate matrix, applied directly to the spinal cord at the time of fetal surgery, would reverse this matrix, and that the animals would walk almost like a normal animal. So we then started down the long path of trying to get funding for this. And again, I first applied to the NIH at the time. This was during our first anti-stem cell administration. When I called, a program director called me back and he said, withdraw your grant. The word fetus is in it. I said, but we're helping fetuses. He said, doesn't matter, don't do it. The good news was California had CIRM, the California Institute of Regenerative Medicine. They were there when we needed them, serendipitously, and they basically have funded almost all of this work. The last work has been funded by Shriners. So we were able to submit an IND to the FDA. They didn't close us down. And we were able to proceed with developing clinical grade cells. So unlike when I was in the laboratory as a resident, you can't just make cells in your lab, mix them up in the roller bottles and give them back to patients anymore. Probably a good thing. We had to engineer our cells in a GMP facility, a special facility designed for sterility to make clinical grade materials for patients. And again, serendipity, Davis happened to have the only one in Northern California at the time. Now there are many. We collected placental tissue from 16 donors. We screened them for infectious agents. We went through all the necessary activity to generate the release criteria. And indeed, they funded us now for what is called the CURE trial. And the cellular, again, I also thought this was a pretty cute acronym, cellular therapy for in utero repair. I left off the M because I'm thinking it'll be cellular repair for cleft lip, cellular repair for, you name it, cellular repair for gastroschisis by Dr. Hiroshi. There will be lots of other things. I will say I can share that the Data Safety Monitoring Board then, after the first 6 patient, gave us the green light to continue just as this patient arrives. We initially had to wait until the baby was delivered to make sure that we didn't generate any little stem cell aliens or something in there. They were very nervous about us putting stem cells inside a fetus. But so far, no unexpected adverse events. So I have to say, it has been absolutely an extraordinary privilege to take an idea in one's head through the bench work and the preclinical animal work to first in human clinical trials. Despite the frustrations along the way, the experiments that didn't work, and the ever present political and financial challenges, I have always been able to find joy in an experiment done properly, a student excited about something they learn, or a great case completed. It is this joy of discovery, that fuels the surgeon scientist and keeps us inspired to keep going despite the everyday RVU, EMR challenges around us. If surgeons don't ask and answer questions, the world will be a much sadder place for humankind. For all those patients whose lives have been saved by open heart surgery, for the multiple people who have come off dialysis and received a transplant, and for the lifetime saved and improved for children who have been able to receive physiologically life-changing interventions as a fetus. And for all these reasons, we must preserve and grow the surgeon scientist. We must persist through the challenges that are coming our way and pivot to position ourselves once again to make the changes that will be necessary in medicine to regain the privilege and the control of diagnosing and treating disease, of caring for the sick and injured, and of making the discoveries that improve human health, of returning to touching the patients rather than the computers, but to embrace the technology, be it machine learning or artificial intelligence or remote care, that will allow this to happen. We must make these changes. Winds of change are blowing fiercely over American medicine today. I want to end with the challenge that we commit to leading, not be led by, the changes in the entire medical industrial complex so that it returns and serves the core mission, providing care and cures to the sick and injured in our shared humanity worldwide. Medicine must not be for profit. It is wrong for someone to make a profit because you were unlucky enough to have a baby born with a birth defect. It is wrong for someone to become wealthy because you developed breast cancer, or you developed prostate cancer, or AML, or bladder cancer. Let us make great discoveries and figure out how to give them away at cost and to return to our core jobs. Only then will we restore the faith and trust of our fellow citizens, and those are the people we serve, our neighbors and our friends. We will have to eliminate the crisis of conscience and the moral injuries that our doctors have experienced. And this, if we return to our core mission, this problem will be solved. We might make less money. But if money is your first goal, I have news for you. You are in the wrong profession. Look at your friends who are in other professions. This is not the goal if money is your first goal. Healing is not for you, because healing takes passion, precision, patience, devotion, sacrifice, and caring. In the words of a great anthropologist, Margaret Mead, never doubt that a small group of thoughtful, committed citizens can change the world. Indeed, it's the only thing that ever has. Thank you, and thank you to the Strauss family for making this possible.
Good choice, right? Inspiring. I actually, we have a little time. I want to see if there's any questions for Dr. Farmer. Dr. Farmer, come on up here. I'm sure there's going to be questions, and if not, Shin will make one up. Dr. Johansson.
Yes.
A statesperson-like presentation, and I'm so proud. This is a clinical question. Congenital defects rarely develop in isolation. Many of these, if not most, are accompanied by other congenital defects. Are those sought in the individuals who might be candidates for the surgery that you do? And does the number of them or the potential severity of them govern your decision-making about whether to undertake the fetal surgery at all?
Great question, Kai. And again, from the very bottom of my heart, thank you for all that great advice long ago. I'm so glad you're here. So you are correct that one of the initial criteria for fetal surgery has been that there was a single anomaly. It's interesting, as we both get better at fetal surgery and we get better at prenatal diagnosis, almost all these patients receive a prenatal MRI now, and it's requiring a whole new level of radiology expertise to diagnose things before birth. It's a little bit different. Plus, they wiggle around in there. One of the original criteria was that it was a single lesion, but we are starting to see that there are some that may not be as impactful and that might not prevent a fetal operation. One of the things that I think is fascinating about congenital anomalies is that there doesn't seem to be an infinite array of them. We never see a baby born with a nose in the middle of their forehead. I mean, there are just certain things that happen in patterns that if we could understand why that occurs, we would have much greater insight and maybe even could correct things even before the fetal stage. I would say in utero, gene therapy, embryonic gene manipulation are all things that I think are in the future for people here. But the in general answer is one disease, one operation. Mark Meisner and I were interns together. I don't know what a vascular surgeon is going to ask me.
Well, I was just going to say that was just a fantastic talk, Diana. Really enjoyable, and I think for all the residents in the room, it was such an honor to see you here today and have trained with you in the past. And I think if all the residents just look at who's sitting next to you, people that you're training with, and realize that one day one of these people sitting next to you may be the next Diana Farmer up here giving that. So really honored to have trained with you, Diana. May I ask you one question? I know nothing about that long word that Doug can't pronounce either, meningomyocele, but you talked about the two-hit hypothesis with it and spectacular success with the second hit, I think. Is there hope for the first hit at that neural tube derangement going back a step? Is anything being done to research that, and how far off till we address the first hit from it?
So you are the perfect example of the importance of the obvious question that sometimes we just don't see in front of us and don't ask. So absolutely, that's the right thing to do. So we don't have to be doing all this nonsense, is to figure out how to prevent the first hit. And that takes really smart people. And so that's that side of the room. No offense over here. But absolutely, that's what we should be doing, is figuring out how to prevent the first hit, so the second hit doesn't even happen. You were a smart guy, Mark. Can I call you a traitor here? No, I guess not.
Well, I got called out by Dr. Wood. So, Diana, it's great to have you here, and I take this opportunity to thank you for all of your advice over the years. So, thank you so much, and it's great to see you here. you alluded to this in your talk, and I just wanted to have you say a few words of how you feel about the culture of innovation today in medicine, because I can tell you the stories that we would tell about Mike would not fly today for a nanosecond. And not only is it different in terms of oversight, but in terms of other administrations getting involved in surgical innovation, in particular the FDA. And I'm curious to hear your thoughts on that.
So this is a really fundamentally interesting question for surgical innovation. If you think about it, almost every operation that we've done, we just made up, right? We surgeons over the years, the Bill Roth 1, the Bill Roth 2, there was no regulatory board. So this is different for us than our internal medicine colleagues, because medicines have been regulated pretty early, which was good. After the days of all the snake oil salesmen and all the stuff in the early days of heroin and cocaine and sort of unregulated use of medications, partly because they were widely available, I think. Surgery has been largely unfettered by this kind of regulation when it didn't involve a device. What's different now is with the robot that requires device development. The FDA struggles about when do you not need oversight? Is it oversight for the instrument or is it oversight for the operation? I do think the FDA is kind of creeping into the operation phase of things. And I think we should guard against it. But that requires that we surgeons stick to the highest level of integrity about what we're doing. And as the financial pressures increase on all of us, and as competition sort of becomes part of what we do, it is harder to maintain that integrity, I think, as a profession. We all know stories, but it is absolutely incumbent upon us to maintain the integrity of our profession in order to maintain the trust of the populace and to avoid some of the regulation that I think would have slowed down the development of almost everything: open heart surgery, transplantation, all of these things that were innovative procedures that wouldn't have happened without someone sort of having the intestinal fortitude to do it in the first place, but also a little bit of freedom to do it in an ethical and responsible way. And that is something I really learned from Mike. As crazy as he was on some levels, he really understood how important it was to do this in a way that would be responsible to the public. Great question. Thank you again, Doug.
Well, and I wanted to thank Mark for calling me out on not being able to pronounce myelomeningocele, which I haven't said for 30 years until I was up here. So just an advice, if you've got a complicated word, practice it like twice before you get up in front of the audience. That's not one that usually comes up in my normal discussions. I just want to thank Dr. Farmer for being here. We have the medal that is the Strauss Memorial Lecture Medal as a remembrance of your time here.
Thank you so much. Thank you,
Thank
Doug.
you.